Welcome back to the deep dive. Our mission here is, well, it's pretty simple. We take a mountain of clinical data, all your sources, your notes, your textbooks, and we forge a definitive, actionable roadmap that you can use the moment you step onto the ward.
We're here to give you that clinical confidence.
Exactly. And today, we're tackling one of the most frequently seen, yet often poorly handled problems in both abdominal surgery and general medicine.
The renal mass.
The renal mass.
Yeah.
A patient comes in with a palpable lump in their flank and, suddenly confusion reigns.
Oh, absolutely. Is it the kidney? Is it the spleen? Or maybe it's the liver or even the colon. This initial misclassification, it leads to all sorts of problems. Inappropriate exams, delays in diagnosis, and often premature or totally unnecessary investigations.
Okay, so let's unpack this a bit. Our sources for today really emphasize moving past that rote memorization. This isn't about just reciting a long list of causes for kidney swelling.
No, not at all. It's about structured clinical reasoning.
This deep dive is built on an anatomy-based, exam-oriented approach. By the time we're done here, you should be able to confidently differentiate a right renal mass from a left one, understand which questions literally save lives, and know the exact sequence of investigation.
And this whole framework is designed for maximum clarity and, safety in real clinical practice. It doesn't matter if you're taking your board exams or seeing a patient for the first time as a junior consultant.
Right.
Precisely. We are building a scaffolding for your clinical thought process. So when you walk into that room, you shouldn't feel overwhelmed by all the possibilities.
You have a plane.
You should immediately be able to categorize the problem and know, say, the 3 essential moves to make with your hands and the 2 essential questions to ask with your voice.
Perfect. So let's lay out the territory for everyone. We're going to start with the non-negotiable anatomical facts that really they define our entire examination strategy. Then we'll move on to cataloging the critical causes, diving deep into the 6 highest yield historical clues. And then, and this is key, we're going to spend some serious time on the systematic physical examination.
Including those crucial differentiation techniques for right versus left masses.
Exactly. We'll finish up with a robust strategy for investigation and diagnosis-specific management. So let's jump straight into the groundwork.
Let's do it.
When we talk about any mass, the first question is always, where did it come from? And for the kidney, location is just everything. So give us the defining anatomical truth about the kidney's position.
The defining truth, the clinical cheat code really, is that the kidneys are retroperitoneal.
Retroperitoneal.
Right. They are not free-floating within the abdominal cavity like, say, the stomach or the small bowel. They're fixed quite firmly against the posterior abdominal wall, lying on either side of the vertebral column. They extend roughly from the 12th thoracic vertebra, T12, down to the 3rd lumbar, or L3.
That retroperitoneal location immediately sounds protective, tucked way back there. So why, then, are we often able to feel a mass that starts from such a deep location?
That's an excellent point. It's because while they are fixed to that posterior wall by the renal fascia, we call it Gerota's fascia, that fascia still allows for some displacement and movement against the posterior muscles.
Oh, yeah.
And of course, a renal mass, just by its size, it has to project forward into the abdominal cavity before it ever becomes palpable. But because the kidney is so deep, palpation is, well, it's structurally difficult.
And that difficulty, that dictates our first clinical implication, doesn't it?
It absolutely does. Because they're so deep, you cannot adequately examine a kidney mass with just one hand. It's just not possible.
Right.
You absolutely require bimanual palpation. You need one hand placed posteriorly in the costovertebral angle to provide resistance, and then the other hand pressing deeply from the front. If you skip this step, I guarantee you will miss a significant percentage of renal masses, especially the early or moderate-sized ones.
Yeah. Bimanually palpable. Got it. Check. Now let's talk about that specific type of mobility we're looking for, which is, pretty unique to the retroperitoneum.
That unique movement is called ballotability. This is the single greatest piece of evidence you will get during a physical exam to confirm a mass is from the kidney.
Ballotability.
Yes. Because the mass is contained within that fascial space, when you push it forward with your posterior hand, it doesn't just float away. It hits your anterior hand, and then it rebounds back against the posterior muscles.
It bounces back.
It bounces back. It's like pushing a basketball that's partially submerged in water. It returns to its original position. A mass that's fully intraperitoneal, it tends to be mobile, sure, but it rarely has that characteristic rebound or ballotability.
I remember learning that the key is the anchor. It's fixed enough to bounce back, but not so fixed that it can't move at all.
Yeah.
Wait, if the right kidney is slightly lower than the left, is that purely because the liver is sitting on top of it? And does that have a clinical consequence?
Yes, that's exactly right. The right kidney sits a bit lower than the left, maybe half a vertebral body lower, because it has to accommodate that voluminous right lobe of the liver superiorly.
Makes sense.
And the clinical consequence is mainly in the differential diagnosis. A right renal mass is much more easily confused with a liver mass or gallbladder pathology than the left is with the spleen, simply because the liver is its closest superior neighbor. We'll get into how to differentiate that later, but that slight offset is anatomically crucial.
Okay, let's talk about the movement relative to breathing. This is a critical differentiator from almost every other major abdominal organ.
This is your number one differentiator against the liver and the spleen. Because the kidneys are fixed to that strong posterior fascia and are only indirectly related to the diaphragm, renal masses usually do not move significantly with respiration.
That's so counterintuitive.
It is. They might descend a tiny bit, maybe a centimeter or two, but they do not sweep down with the diaphragm the way the liver or spleen does. This lack of respiratory movement is your key clinical pearl. Most people assume a large mass will move, but the kidney, because of its deep fixation, it defies that expectation.
So we've got bimanually palpable, palatable, and little to no respiratory movement. What about the fourth key finding, the ability to get above the mass?
This simply means trying to define the superior border of the mass. If the mass originates high up under the ribs, think a huge spleen or a severely enlarged liver, it can feel like it just vanishes under the costal margin. It's impossible to slip your fingers underneath it.
Right.
But because the kidney generally sits from T12 to L3, if the mass isn't absolutely enormous, you can often, not always, but often feel the top pull. You can get your fingers between the costal margin and the superior edge of the palpable mass. This helps confirm it's from the kidney rather than a massive superior organ.
This all synthesizes into the ultimate shortcut for confirming where the organ comes from. Let's give the listener that definitive rule, the one derived entirely from the anatomy.
The ultimate shortcut, the diagnostic money line, is this. If you can ballot the mass and you cannot feel it move significantly with breathing, think kidney first.
That's the one.
That technique is so specific to the retroperitoneum that it virtually guarantees you are in the right anatomical territory.
That gives us the foundation. We know where it is. Now we have to figure out what it is.
Exactly. And once we're confident the mass is renal, systematic categorization is vital. We don't want to jump straight to the scariest possibility. We need a framework that covers the full range of pathology.
And we do that by organizing the causes into four broad pillars.
4 pillars. Number 1 is neoplastic causes. 2 is obstructive, 3 infective, and 4 is congenital or cystic conditions.
Okay, let's break down that neoplastic category. What are we primarily thinking about, depending on the patient's age?
In adults, the absolute priority is renal cell carcinoma, or RCC. This accounts for the vast majority of primary renal malignancies. It's often called the internist's tumor because it can present with really vague symptoms or paraneoplastic syndromes, not just localized mass effects.
I'm in kids.
In children, we shift our focus dramatically to Wilms tumor or nephroblastoma, which requires a rapid diagnosis and an entirely different oncological management plan.
Of moving to obstructive causes, what does this usually mean in the clinic?
Hydronephrosis. This is kidney swelling because of a backup of urine. The urine can't drain out, so it distends the renal pelvis and the calyces. This is usually caused by an obstruction somewhere in the ureter, a stone, a stricture, or even external compression from a pelvic mass.
Yeah, that's urgent.
It's very urgent because if that pressure isn't relieved, the increased hydrostatic pressure will quickly destroy the functional nephrons of the kidney, potentially leading to irreversible renal failure.
Then we have infective causes.
The primary concern here is a renal abscess. This is a localized collection of pus within the kidney itself or in the surrounding fat, a paranephric abscess. This is often a complication of an ascending UTI or, less commonly, from hematogenous spread from a distant infection.
And this patient will look sick.
Oh yeah, this presents as an acutely ill patient, often with systemic sepsis.
And finally, congenital or cystic conditions.
This bucket includes the chronic bilateral condition of polycystic kidney disease, or PKD, which involves hundreds of cysts replacing the normal kidney tissue, and it also includes simple, often incidentally found, renal cysts.
How do those differ in importance?
Well, a simple cyst is typically benign. But PKD is a systemic disease that leads really inexorably to chronic kidney failure. It requires careful long-term management of complications like hypertension and recurrent infections.
That covers the full spectrum. But in an adult clinic setting, you can't chase down all four categories equally, which too demand our immediate critical attention.
In the adult population, your triage must prioritize renal cell carcinoma and hydronephrosis.
Malignancy and obstruction.
Exactly. RCC is the life-threatening malignancy. Hydronephrosis is the time-sensitive, potentially function-destroying emergency. Everything else is still important, of course, but those two dictate the speed and urgency of your workup. And we use the patient's story, the history, to start separating them.
We've used anatomy to confirm the masses from the kidney. Now, the patient's narrative becomes our differential diagnosis generator. We need to go beyond the basics and look for specific qualities in their symptoms. Let's talk about the 6 key areas.
Right. Pain, hematuria, fever, weight loss, LUTS, and past or family history. Let's start with pain. You need to explore its character meticulously.
Okay, so how does the quality of the pain guide us specifically between those two high-priority concerns, hydronephrosis and RCC?
Well, it's often a tale of two different speeds. With hydronephrosis, if it's chronic, the swelling is gradual, leading to a stretch on the renal capsule. This results in a persistent, dull, heavy aching pain in the flank or loin.
A sort of uncomfortable pressure.
Exactly. The patient might describe it just like that. But if that obstruction suddenly worsens, let's say a stone drops into the pelviureteric junction, the pressure spikes rapidly. That leads to the classic, severe, agonizing colicky pain that radiates down to the groin or testicle.
So ball ache is a chronic plumbing blockage. Colicky pain is an acute one. Now, what about the pain from RCC?
This is the critical finding you have to internalize. In renal cell carcinoma, pain is usually a late and ominous feature. These tumors can grow quite large before they stretch the capsule enough to cause any real discomfort.
So no pain is actually a bad sign.
It can be. If a patient presents with a large, palpable mass but reports little or no pain, or the pain is recent and mild, your clinical index of suspicion for malignancy must immediately go way up. The classic RCC triad, which, we rarely see anymore because we catch these tumors earlier, is a palpable mass, pain, and hematuria. Finding the mass without the pain is often a red flag in itself.
That absence of early severe pain is a powerful negative diagnostic clue for malignancy. Okay, let's move to the ultimate red flag. Hematuria. Why is this so crucial and what defines its malignant presentation?
Hematuria means blood in the urine, and its presence demands immediate, rigorous investigation. The key clinical pearl for malignancy is painless hematuria.
Painless.
Painless, gross, or visible hematuria without any discomfort. The blood is passed because the tumor erodes into the collecting system, but because there's no stone irritating the ureter or causing muscular spasms, there's just no pain. Any adult reporting painless hematuria must be treated as having a malignancy until proven otherwise.
And you mentioned its intermittent nature is also a huge clue for RCC. Why is it often on again, off again?
Yes, the intermittent or transient nature is a classic pitfall. A small part of the tumor might ulcerate and bleed for a bit, but then a clot forms, stopping the bleeding for days or even weeks.
And the patient thinks they're fine.
The patient sees the blood disappear and assumes the problem has resolved. That silent interval is the tumor's opportunity to progress. We have to specifically ask about past episodes, even if they happened months ago that might have been dismissed. Also, look out for thread-like clots. While clots can happen with any major bleed, large, irregular clots can sometimes point toward a large tumor surface.
Let's discuss fever. How do we use the quality of the fever to separate the infective processes from the systemic ones?
Fever tells us about inflammation. If the patient reports a high-grade, spiking fever temperatures reaching, 102 Fahrenheit or higher, and it's accompanied by chills and rigors, that violent shaking,
Right.
that points overwhelmingly to an active acute infectious process, probably a renal abscess or severe pyelonephritis. It's a septic picture.
And how does that contrast with malignancy?
Well, with malignancy, RCC can cause a low-grade, often persistent fever. This is either due to the tumor secreting pyrogens or as a manifestation of a perineoplastic syndrome. That high spiking temperature is the key differentiator for acute infection.
Speaking of perineoplastic syndromes, we should probably elaborate on the systemic questions that go beyond just weight loss.
Absolutely. The next major historical pointer is weight loss and appetite. Unexplained, significant weight loss paired with anorexia, loss of appetite, are extremely potent red flags for advanced malignancy. But we also have to specifically ask about other paraneoplastic symptoms linked to RCC,
Like what?
like unexplained new onset hypertension, which can happen from renin secretion, or erythrocytosis from erythropoietin production, or even vague muscle weakness and hypercalcemia. These systemic symptoms, when you pair them with a mass, are highly diagnostic of RCC even before you get any imaging.
Wow, those systemic symptoms really connect the dots between oncology and endocrinology.
Ah!
Moving on to the lower end of the urinary tract. Lower urinary tract symptoms, or LUTS.
The presence of LUTS, so frequency, urgency, nocturia, hesitancy, that doesn't point to the mass itself, but it points to the underlying mechanism. Severe LUTS often suggests a problem downstream, like benign prostatic hyperplasia in men, which is causing obstruction and leading to hydronephrosis upstream.
Or infection.
Or infection, exactly. LUTS might suggest a cystitis that has spread up to cause pyelonephritis or a renal abscess. It tells us the pathology involves the plumbing system, pushing us toward either the obstructive or the infective categories.
Finally, past and family history. We need to fish for risk factors and inherited diseases here.
This is critical for context. If the patient has a history of prior renal stones, we know they're prone to future obstructive events and therefore are high risk for hydronephrosis.
Okay.
If they have recurrent, poorly treated UTIs, they are prone to chronic infection and abscess formation. And most critically, always ask about family history. If a patient reports multiple family members with kidney failure or large kidneys or needing dialysis, you must immediately consider polycystic kidney disease.
Because it's inherited.
It is. It's an inherited disease, and a strong family history is often the first and most powerful diagnostic clue you'll get.
That's a highly detailed framework. We have used the patient's story to generate our prioritized differential diagnosis. Now we use our hands to test those hypotheses.
The examination is where that abstract anatomical concept of the retroperitoneum becomes a clinical reality. We have to follow the strict sequence: inspection, palpation, percussion, and auscultation.
What are the key visual cues we must identify during inspection?
First, look for general systemic signs. Is the patient jaundiced? Are they pale, suggesting chronic anemia from occult bleeding? Then you focus on the abdomen. Look for flank fullness or abdominal asymmetry. Compare the two sides. Does one side bulge more? Also, look for signs of advanced disease, like visible venous collaterals, or, critically, signs of cachexia.
That muscle wasting.
Yes, that wasting of muscle mass, which, paired with the mass, points fiercely toward malignancy.
Palpation is the centerpiece. We need to confirm size, surface, consistency, tenderness, and most importantly, those unique retroperitoneal signs. Let's talk about consistency. How does that guide our differential?
Consistency is vital for triaging. A mass that feels smooth and soft or fluctuant immediately suggests a cystic origin. So you're thinking a simple cyst, PKD, or hydronephrosis, which is essentially just a bag of water.
When a solid mass.
An irregular, nodular, or firm to hard mass raises the alarm for a solid tumor like RCC.
What about tenderness? When should a renal mass hurt, and when should it not?
Typically, an uncomplicated renal mass, like a tumor or stable PKD, is non-tender. The kidney is deep, the mass is chronic. Acute tenderness, however, suggests an acute inflammatory process, either a rapid stretch of the capsule due to acute obstruction, that colicky pain, or, more specifically, an active renal abscess or severe pyelonephritis. Tenderness is your indicator of urgency and infection.
Let's focus on the crucial maneuvers. Explain again the necessity of executing ballotability correctly.
You have to remember, you must use both hands. The posterior hand is used to dislodge or lift the kidney forward, pushing it against the anterior hand, which is pressed deep into the flank. You're waiting for that distinct, subtle pop or rebound sensation.
And if you feel it.
If you feel it, you've hit the bullseye. You are dealing with a retroperitoneal organ. Without ballotability, even a fixed abdominal mass is unlikely to be from the kidney. It defines the organ's origin.
What if the mass is absolutely colossal? I mean, so massive it fills the entire flank. Does it lose its ballotability?
That's a great nuance. And yes, if the mass is truly massive, say 15 centimeters or larger, it may become so fixed or fill the space so completely that it loses its characteristic ballotability.
So what do you do then?
In those rare instances, you have to rely even more heavily on the lack of respiratory movement and the percussion finding to confirm the renal origin. You look for the signs that just don't fit the liver or spleen pattern.
Let's move to that counterintuitive clinical clue. Percussion. Why on earth does percussing over a deeply embedded, solid kidney mass yield a resonant note?
It's purely anatomical, and it's a brilliant shortcut. Since the kidney is retroperitoneal, the entire large bowel, the ascending or descending colon, and the small bowels sit anterior to the mass.
They're draped over the front of it.
Exactly. So when you percuss over the mass anteriorly, you are percussing over the gas-filled intestine that is draped over the kidney, and therefore you elicit a resonant note, or sometimes even a tympanic note.
I can imagine how this one detail saves a trainee. So if you find a firm, palatable mass on the left, and you percuss over it and hear resonance, what does that immediately rule out?
It immediately and powerfully argues against massive splenomegaly. A massively enlarged spleen often pushes the gut loops posteriorly and out of the way, making the spleen itself dull to percussion over its anterior surface. That resonant percussion note tells you the mass is deep, behind the gut, placing it firmly in the retroperitoneum.
It's a critical differentiator for both right and left upper quadrant masses.
Absolutely.
That's a phenomenal detail, one that really sticks in the memory. Finally, auscultation. It's rare, but what are we listening for?
We're listening for a vascular bruit over the mass or in the flank. While it's infrequent, a bruit suggests turbulence in the renal artery. This can be caused by the tumor invading the vessel. Think of an angiomyolipoma or a highly vascular RCC, or conversely, severe renal artery stenosis that's causing secondary hypertension. If you hear a bruit, you're adding a high level of vascular complexity to your investigation.
Okay, we've established the mass is renal, but the real clinical test comes when we have to prove it's not the liver on the right or the spleen on the left.
This is it. This differentiation is the highest yield segment of the entire physical exam.
Let's start with the right renal mass challenge. Since the right kidney is a bit lower and the liver is immediately superior, what is the primary confusion and how do we resolve it?
The confusion is distinguishing a large right kidney mass from an enlarged liver, hepatomegaly, or a mass that's actually starting in the liver itself. And the resolution hinges on respiratory movement.
Explain that contrast in movement again, focusing on the mechanism.
The liver is essentially an intraperitoneal organ. It's suspended by ligaments, but it's highly mobile and immediately attached to the diaphragm. When the patient takes a deep breath in, the diaphragm descends and the liver sweeps down significantly, often 4 to 8 centimeters.
And the kidney.
The right renal mass, being retroperitoneal, is tethered to the posterior wall. It only moves minimally, maybe 1 to 2 centimeters at most. So if the mass moves substantially upon deep inspiration, you should strongly favor a liver origin. If it stays put, you favor the kidney.
That is the single most important clinical maneuver on the right side.
Without a doubt.
And we can't forget the percussion clue here either.
Exactly. A large, solid liver mass will present a dull percussion note across its anterior surface. But a right renal mass will often retain that telltale anterior resonance because of the intervening ascending colon. It's another layer of evidence that the mass is resting behind the gut.
Now let's move to the left renal mass challenge. This is perhaps even more commonly confused because the spleen and kidney share similar positions and consistency. How do we definitively separate splenomegaly from a left renal mass?
This is where we apply the inverse rules, and this is where ballotability is an absolute lifesaver. We need to compare the defining features side by side.
Okay, so let's define the 3 hallmarks of an enlarged spleen first.
First, the spleen moves significantly with respiration. It follows the diaphragm, sweeping down and across. Second, a massively enlarged spleen is not ballotable. You can't push it back and feel it rebound because of its peritoneal attachments and the way it sits in the upper quadrant.
And the third?
Third, the examiner often cannot get above it. It's situated so high up against the diaphragm. Furthermore, a grossly enlarged spleen expands downward and medially, and you can often feel a sharp medial border and sometimes the splenic notch, which are signs unique to the spleen.
And now, for the left renal mass, the exact opposite set of signs.
The left renal mass will be ballotable. It will exhibit minimal respiratory movement, and you can often get above it, defining the superior pole. That triad of findings trumps everything else. If the mass is firm and fills the left flank, but you can feel it bounce between your hands, you have found the kidney.
This whole section culminates in that high-yield phrase, the ultimate summary for the listener to take away.
You need to know this phrase cold. Respiratory movement favors spleen, ballotability favors kidney. If you remember nothing else from the physical exam, remember that differential aphorism. It is the defining rule for distinguishing the 2 most common left upper quadrant masses.
What about the case where the kidney mass is so large it pushes the spleen out of the way or even fuses with it? Does that happen?
It can, but only in extremely advanced, locally invasive disease. In those cases, the mass loses its classic ballotability and may exhibit some transmitted respiratory movement. But critically, even then, the mass is often fixed, hard, and associated with cachexia and the systemic symptoms we found in the history, pushing you toward an urgent malignancy workup regardless of the precise origin.
So you follow the evidence.
Always. History, then hands, then imaging.
We've completed the clinical encounter, and we have a strong clinical suspicion, likely polarized toward RCC or hydronephrosis in an adult. Now we move to confirmation. But before we order a single test, we need to explicitly review our structured differential diagnosis.
Yes, this conscious review prevents cognitive bias. We have to confirm or exclude in order of urgency. Number 1, renal cell carcinoma. 2, hydronephrosis. 3, renal abscess. 4, polycystic kidney disease. And 5, paranephric abscess. The rule remains, prioritize the life-threatening and malignant causes first.
And our investigation sequence flows directly from this prioritization.
Exactly.
Let's start with the baseline tests. These are the quick, foundational tests that often confirm our suspicions from the history.
We begin with the basics. The complete blood count, or CBC, is essential. Anemia can indicate chronic microscopic hematuria from RCC, while a high white count, leukocytosis, strongly suggests infection, pointing us toward an abscess.
And kidney function.
Next, renal function tests, or RFTs. These are non-negotiable. Why? Because hydronephrosis is an obstructive process that can destroy renal function. RFTs tell us if the patient is already in renal failure and how urgently we need to intervene.
And the final baseline test is analyzing the product of the organ itself.
That's the urine routine and microscopy. We confirm or exclude hematuria, which supports malignancy or stones, and we look for pyuria pus cells in the urine or bacteriuria, which confirms infection and often directs our antibiotic therapy immediately if we're suspecting an abscess.
Okay, now we move into the imaging sequence. What is the definitive first-line imaging that helps us triage this entire problem list?
That is the ultrasound abdomen. An ultrasound is inexpensive, non-invasive, and available immediately. Its utility is enormous because it provides the essential first answer. Is the mass cystic or solid? This single piece of information radically refines the differential.
So how does the ultrasound help us triage cystic versus solid?
If the mass is purely cystic, meaning it meets all the strict criteria, smooth walls, no internal echoes, good through transmission, it's usually a benign, simple cyst. If it's a complex cyst with thick septae, calcification, solid components, we immediately escalate the investigation.
And for obstruction.
Ultrasound is also the gold standard for visualizing hydronephrosis. It shows that characteristic bear claw pattern of dilated calyces and a fluid-filled renal pelvis. If it's solid, the alarm bells ring very loudly for RCC.
So if the ultrasound suggests a solid mass or a complex cystic mass, we immediately move to the gold standard imaging modality.
The gold standard for suspected solid renal masses and for staging is the contrast-enhanced CT scan, or CECT. This is mandatory for a malignancy workup. The CECT answers 3 crucial questions that determine management.
What's the first question?
Confirmation and extent. The CECT confirms the solid nature of the mass and precisely defines its relationship to critical adjacent structures, like the renal vein, the inferior vena cava, and the collecting system.
And the second?
Staging. It defines the tumor stage, the TNM staging. Has it invaded the renal capsule, the perirenal fat? Has it involved the adrenal gland? Most critically, CECT assesses for local and distant spread, particularly looking for enlarged retroperitoneal lymph nodes and liver metastases.
And the third question, which ties directly back to surgery.
Operability and surgical planning. The CECT is essential for determining if a partial nephrectomy, just removing the tumor, is feasible, or if a radical nephrectomy, removing the whole kidney, is required. Factors like tumor size, its location, and proximity to the collecting system are all mapped out, guiding the surgeon's approach.
Are there any specific special tests we use outside of the routine US and CECT?
Yes. In cases of hematuria where the CECT doesn't fully explain the bleeding, or if we suspect a urothelial carcinoma, that's cancer of the lining of the urinary tract, we might order a CT urography, which uses contrast to beautifully delineate the whole collecting system.
What about a biopsy? We hear about fine needle aspiration cytology, FNAC, but many surgeons seem reluctant to use it for solid renal masses. Why is that?
That reluctance is well-founded. Historically, there was a major concern about the risk of tumor seeding along the needle track when biopsying RCC, although this risk is now seen as quite low with modern techniques.
So what's the main issue?
More importantly, FNAC often provides a poor diagnostic yield for classification, and since we plan to remove the solid mass anyway, a biopsy just delays definitive surgical treatment. FNAC is reserved for very specific scenarios.
Okay.
For example, when we suspect the mass is metastatic, not primary kidney cancer, and we need tissue confirmation before starting systemic chemotherapy, or if we suspect a highly unusual diagnosis like a lymphoma, or, crucially, if we are certain the mass is an abscess and need bacteriological confirmation. But for our primary solid mass in a fit patient, we generally proceed straight to surgical excision based on the CECT findings.
That structural sequence baseline test to ultrasound to CECT is so critical. It ensures that every test is justified by the clinical findings and the urgency of the differential.
Exactly. We have successfully used history, physical examination, and imaging to arrive at a confirmed diagnosis. Now we translate that diagnosis into a precise management plan. This is the payoff for all that structured reasoning.
Let's start with the highest priority, renal cell carcinoma. We know the management is surgical, but what dictates the choice between removing the whole kidney and saving part of it?
The standard of care has shifted significantly toward nephron-sparing surgery or partial nephrectomy whenever it's feasible. If we can remove the tumor with a safe margin and preserve the rest of the kidney, the patient retains maximum renal function, which is a major long-term benefit.
Especially if they have underlying kidney issues.
Precisely, or might develop them later.
So what are the key criteria that favor a partial nephrectomy?
Generally, a partial nephrectomy is favored for smaller tumors, typically less than 7 centimeters and often less than 4. We also look for tumors that are exophytic, meaning they bulge out from the kidney surface, making them easier to excise without cutting deeply into the collecting system.
And when is it mandatory?
If the patient has a solitary kidney or bilateral tumors, NSS becomes mandatory. But if the tumor is large, endophilic, meaning deeply embedded, or shows evidence of significant renal vein or IVC invasion on the CECT, then we have to proceed to a radical nephrectomy. Total removal.
And what follows the surgery?
Following accurate staging, management follows strict oncology protocols. While chemotherapy is generally ineffective for RCC, localized recurrence and advanced cases require specialized approaches, including targeted therapies like tyrosine kinase inhibitors and increasingly immunotherapy like checkpoint inhibitors.
The key takeaway being?
Early clinical suspicion and diagnosis leading to surgical excision of localized disease significantly improves the 5-year survival rate.
Moving to the obstruction issue. Hydronephrosis. This is often an acute problem that needs rapid decompression. How do we manage this and what drives the immediate decision?
Management hinges on urgency, specifically whether the obstruction is complicated by infection, which leads to pyonephrosis pus in the kidney, a true urological emergency.
So if the patient is septic, what's the immediate move?
If a patient has an obstructed, infected kidney and is septic, the immediate goal is source control. We need to drain it. We bypass the obstruction. This is often done using a percutaneous nephrostomy tube, a tube placed by interventional radiology directly into the renal pelvis through the back to drain the infected urine externally.
And that's often safer than a stent.
In a septic patient, yes. It's often safer than attempting an internal ureteric stent because manipulating that infected system can sometimes push bacteria into the bloodstream and worsen the sepsis.
So nephrostomy for sepsis, stenting if they're stable.
Broadly, yes. If the patient is stable and non-septic or the obstruction is purely chronic, we might opt for a ureteric stent to allow urine to bypass the blockage internally. But regardless of the immediate technique, the next step is mandatory, treating the underlying cause.
Decompression is stabilization. Treating the cause is the cure.
That's it, exactly.
Let's discuss polycystic kidney disease. This is chronic and systemic. What's the long-term focus?
Since PKD is a chronic, relentless condition, management is primarily medical and supportive. The goal is to slow disease progression and manage complications. The single most important factor to control is hypertension.
Why blood pressure?
Aggressive blood pressure control using agents like ACE inhibitors is vital because uncontrolled hypertension drastically accelerates cyst growth and kidney damage. We also manage pain, recurrent cyst infections, which require lipophilic antibiotics that can penetrate the cyst walls, and just general cardiovascular health.
And when do they cross the line into end-stage management?
When their kidney function deteriorates to end-stage renal failure, patients inevitably require renal replacement therapy. This means preparing them for long-term dialysis or assessing their suitability for a kidney transplant, which is the definitive treatment for advanced disease.
Finally, the infectious cause. Renal abscess. When does the imaging we discussed earlier guide the drainage?
A renal abscess requires a dual-pronged approach: systemic control and local drainage. Broad-spectrum antibiotics are started immediately. Then, image-guided drainage is the critical step. Using CT or ultrasound guidance, a drainage catheter is placed percutaneously into the abscess cavity to empty the pus.
And that usually works.
It's successful in the majority of cases, and it minimizes morbidity.
So when do we resort to open surgery for an abscess?
Surgery, usually partial or total nephrectomy, is strictly reserved for abscesses that are refractory to treatment. So, cases where the infection persists despite adequate antibiotics and multiple attempts at percutaneous drainage, or if the abscess is so destructive that it has already converted the kidney into a non-functional septic sac. Surgery is the last resort, not the first.
We have spent substantial time today integrating anatomy and the clinical encounter into a really powerful diagnostic framework. We've moved from the single anatomical fact of the retroperitoneum all the way through to diagnosis-specific surgical and medical decision-making.
The goal for all of you listening was to replace confusion with a logical, systematic process. You should now have those immediate clinical tools right there in your memory.
Let's recap those core actionable insights, the rules the experts follow. First, when you encounter an abdominal mass, immediately apply the anatomy. It is retroperitoneal.
Right. The kidney mass is deep and tethered, not free-floating.
Second, you must master the use of ballotability and percussion.
Ballotability is the gold standard clinical test for kidney origin. And that anterior resonance, due to the overlying colon, is the ultimate shortcut for confirming the mass is deep behind the gut.
And third, you have to know the precise signs to differentiate kidney from spleen and liver. Forget long lists, just remember the money line for the physical exam.
Respiratory movement favors spleen, ballotability favors kidney.
And finally, remember that your clinical reasoning precedes and directs your imaging orders. You use the ultrasound to confirm if the mass is cystic or solid, and the CECT to stage the malignancy you already suspected from the history and your hands.
Imaging confirms it does not replace the initial clinical thought process.
If you stick to this structured approach, prioritizing the malignant and the obstructive causes, you will always be practicing the safest medicine. What is the ultimate payoff for maintaining this rigorous structure?
The final critical takeaway, the reason we do all of this, is simple. A structured clinical approach prevents missed renal malignancy, saving function and saving lives. That is the singular mandate of this entire deep dive.
A powerful thought to leave you with. We have focused today on the upper abdominal retroperitoneal masses. The logical progression for clinical rigor takes us down into the pelvis, where the masses can be even more deceptive, confusing gynecological origins with general surgical pathology.
So next time, we will take this exact framework anatomy, history, exam, investigation, and apply it to pelvic masses, integrating the necessary gynecological and surgical perspectives to navigate that complex territory.
We'll see you then for the next deep dive.